Thank you for inviting us to be able to speak. It's an honour for my colleagues to and myself to gather together and be able to speak. You can see the names on our front page there that we've got people from all over the world. We've got Dr. AeHIN McNicoll, who's based in the UK, and he's going to tell us a little bit about how the openEHR community response began, and he's going to describe some implementations, especially from a Norwegian point of view. Paolo Anedda is in Italy at the moment. He took a very similar data set to Dr. McNicoll and the Norwegian colleagues, and they've implemented that in Italian in Sardinia, and he's going to tell us about that, that project. I will be speaking a little bit from the point of view of the openEHR International group and how we've done some governance around building some of these data sets and how we're managing that. Professor Liu from China is going to tell us a little bit about his project where he's taken some of those data sets, translated them into Chinese, and then they're implementing around Wuhan. Silje Bakke is from Norway, and she is one of the co-chairs from the openEHR International. I think she was planning to be on the call. I'm not sure if she's here yet, but she is the co-chair, and so she will also be answering some questions with us at the end. But I might hand over now to Dr. AeHIN McNicoll, who's going to start us off.
Thank you, Heather. Let me just check my control.
I'll let you introduce yourself a little bit more detail if you like.
I will once I get onto my first slide. Yeah, good afternoon, everyone. Good evening for most of you. So I'm AeHIN McNicoll. I'm a former GP, general practitioner, family doctor, but I've been working in health informatics for many years now. I'm a board member of openEHR and of other activities. It's a great shame that Bjorn Ness was not able to be here. He's actually sunning himself in Italy because Bjorn in some ways started this part of the project off, and Bjorn's been good enough to give me his slide set, which I think explains the origins of some of the work around COVID-19. So just a little background. For those of you who are not familiar with openEHR, really just one screen, a couple of screens to give you some background. So what is openEHR? Well, it's really a community and industry collaborative around the idea of an open standards-based health and care ecosystem. And in particular, the idea of a clinical data repository, which is a technology and vendor neutral data store. That technology and vendor neutral data store is fed by a vendor and technology neutral information model and a set of tools and methodologies associated with those. And that's very much what Heather will be explaining in more detail. The fundamental difference is we really aim to separate the apps from the data. So rather than everything being tied into the application, we deliberately split out the information models and terminologies and indeed the data stores from the application. And the data is the system, not the application. Right now, most apps are built to handle the data as well as their own functionality. I'm not quite sure what that did, but we'll ignore it. So on to our story. And this story really starts right at the end of February, when Bjorn was speaking to his colleagues in DIPS. So DIPS are a major hospital vendor in Norway. They have hospital sites and a traditional legacy medical system, but they're replatforming that medical system on what they call DIPS Arena, which is based on openEHR, and DIPS are a major contributor to the openEHR story. So around the 20th of February, Bjorn started talking to his colleagues because obviously COVID was really just kicking off, particularly in the Far East and China. And they recognized that they were going to have a problem, in particular in screening for patients who were going to be admitted to the hospital. But he started talking about this to his colleagues, and then he called me one afternoon and said, you know, it's sort of something that feels like it should be a collaborative effort. This is going to happen around the world. Would I be interested in helping collaborate on building the relevant data models? Of course, I said yes. Very interesting. we finished the call. 2 hours later, he called me to say that the very first COVID positive patient in Norway had tested. They'd been sitting in an outpatient department in the major Oslo hospital, had tested positive, and clearly there was major risk of spread to other parts of the hospital. So this suddenly became a very significant project. So the idea went into prototype fairly quickly. We didn't actually, we kept the modeling activity rather quiet for a week or so, because we wanted to make sure that the idea was solid, that this wasn't just us hyping, you know, openEHR and an open platform on the basis of the COVID crisis. Bjorn wanted time to talk it over with his customers. But we did continue doing international development. We started to bring others in to work on the models. And around the beginning of March, the 5th of March, the DIPS Arena prototype went live. We then started to get other vendors involved, in particular Better. You'll hear more about some of the work that Paolo did with Better. So we had a real consortium of actual vendors developing products, and the first product for DIPS went live on the 6th to 8th of March. So that's a matter of days after the idea was first developed. I'm not going to talk about this in detail. Obviously, we'll make the slides available, but this was the basic outline of the app that DIPS were trying to develop. So it was very much about assessing symptoms and then understanding the next steps of what should happen if a patient particularly tested positive. Now, bear in mind that this was in the very early days of the COVID crisis, where really a lot of this information was not particularly not particularly well known. So here's Bjorn's slide where he says our openEHR application was in production 11 days after the ID was born, and it was largely, in fact, almost completely based on international clinical models. So Alva's just asked a question, what was the reason for the quick process? Well, part of that was that we had already had many of the models available. We used these archetype components, and many of them could be repurposed for this particular use case. So based on many years of clinical modeling and a lot of fairly slow and deliberate work getting good quality models, which is very much Heather's territory, we're able to develop, you know, the localized use case information models for this app within a matter of days. So this gives a look at the UI. There's nothing very exciting about it. You know, does the patient have any symptoms? Have they had a positive or negative result? Lots of other issues about risk factors and whether they should be isolated or not. It's a more sophisticated application than you see on these screenshots, but you'll get the idea of what DIPS were doing. And of course, because once you've got openEHR data committed, doing queries on that data via the model definitions is really very easy. So this is some dashboarding information that comes out, including work with the R and Python languages to do more analytics work on the back of it. So my part in this project was very much around the data modeling. We called it Project KOFI. For those of you who are not familiar with the words of Donald Trump, this was a phrase he came out with a couple of years ago. It seemed nobody really knew what he meant, I suspect including himself, but it seemed quite a good name for this project. As I said before, we actually kept it quiet. Although we were working collaboratively, we didn't go public until a week or 10 days in, because we just wanted to make sure we were doing something genuinely useful. At that point, we started to bring others in, particularly Heather, who'd, I think, been on holiday for the first week, or she would have been involved right away. And then if you like, Ninja project that we started with, really was redeveloped and became a more formal project, and Heather will tell you more about that activity in a few minutes. So here's some other applications that were developed around that time, again, based on exactly the same data models. At least the first two screens were based on the first two data models. So this was around the suspected COVID-19 risk assessment, and also a confirmed COVID-19 infection report, which was based on the WHO guidance. So these were deployed very quickly in NHS Taunton, which uses the Better CDR, Clinical Data Repository, and their form building tooling. But that unit, the clinicians themselves in that unit went on to develop further COVID-19 applications very quickly. One to assess patients prior to admission to ICU, and the other to monitor patients during their ICU journey. And these were built very quickly, again, on standard openEHR archetypes. And then along came a whole other bunch of apps, some of which did go into deployment, others are in trial. So Pasienski, Norwegian company, GP system, they use the same archetypes in their purpose. I'm working with an ongoing project in the UK with a company called openEHR, who are adapting those archetypes for other purposes. The top left is a paramedic app used to assess COVID-19 patients in the community, and we've been modelling that in openEHR and SNOMED. So that's just a summary of the overview of the very initial work that went on. Very rapid development. Of course, we made some mistakes, things that we do better, and this was the purpose of the more deliberate openEHR modelling project that Heather and Silje were leading. And at that point, I'll hand over.
Ian, as I just swap over control to Paolo, right, this is going to be speaking next. Can I just get you to give us a summary of how many implementations you're aware of? You've spoken about Norway, 2 vendors in Norway, a couple in UK. Do you have any, can you give us a sense of how many hospitals?
It's really very difficult to know because, of course, people don't necessarily tell us. I'm aware of certainly overall probably 12 or 15 actual applications and probably another 10 or 15 prototypes or attempts. So, for instance, I know that others started down this road and then for various reasons they didn't feel they had a deployable or marketable product. And to some extent, that's because, of course, the requirements in this condition changed as countries went through different phases. You know, we found certainly in the UK that the need for an assessment application has suddenly gone away and there are other apps required. And that's one of the beauties of openEHR, is that we can just keep redeploying, you know, do things very quickly. And, you know, if we waste a little bit of time, and it will be a little time, building data models for apps that don't come into production, then it's not a big deal.
Okay, thank you. Paolo, over to you, please.
Thank you, Heather. Thank you, Ian. Okay, so before going into my presentation, I will give you some words about myself. My name is, you can see, Paolo Anedda. I'm an electronic engineer.
Paolo, can I just interrupt you? Can you speak a little bit closer to the microphone, please?
Yeah, I'm trying to do it. Can you hear me well now? Better?
It's a bit better. It was a little bit fuzzy before. If you could speak closer, it would be good. Okay.
Okay, so I will say, my name is Paolo Anedda, and I'm an electronic engineer. I took my degrees and after my PhD from the University of Calgary, and then I started my career in the researcher, and after I jumped into the software development. Now I'm the head of innovation project at McNicoll, which is a manufacturer company in the field of automation for innovation. Okay, so let me speak about our experience with the COVID-19 fighting initiative. And, my story began with an email sent by Thomas Goring from Better. He sent an email to our president, Davide Pedrazzini, in the beginning of March, probably it was the second week of March. And telling us about this initiative from the openEHR community, and he offered us to support us in whichever initiative we would start with. So after this email, I immediately jumped in and began to study from the openEHR website what the project was about. And then sooner I contacted my friends at the CRS4, which is a research center also in Sardinia, and together we started to brainstorm on the different possible initiatives to launch in Italy. And when we realized that there was already a solid base to start from, we began to study the templates already present in the knowledge base from the website of the openEHR community. And we started from the template of the risk assessment form. Immediately after, we started to reason on what could be our contribution to this initiative. And we started our work by translating every archetype that was associated with the motors, because to translate in Italian, of course, because as you can imagine, language in Italy, we are not used to speaking English in Italy. So our first contribution was to translate all the archetypes associated with this clinical model, initial clinical model. And it took about few days to have all the archetypes translated into Italian. And the next step was to submit our work to the community, to the openEHR community, and we soon received feedback from the community, and so that we can make some adjustments. And in a very few days, we saw our archetypes, actually the translation of our archetypes available to the community in the global repository of the archetypes. Okay, in the meantime, here you can see the slide, the two pictures of the tools that we use to translate the archetypes. In the meantime, we as IMPECO were also involved in several discussions and initiatives with local institutions and organizations to set up a technological infrastructure to support the fighting against the virus. And since in Sardinia, at that moment, the hospital seemed to be the primary site for the infection, and also due to the exposure of the clinical personnel, the attention was focused on delivering a solution to secure the operators inside the hospital, and then to enlarge it to the rest of the team. So the basic idea was to create a solution that could bring together the data coming from a secure and well-traced swab collection process, together with the acquisition of data related to the infection risk. Then the data should have been available in the cloud for later make it available through platform, data visualization platform in the cloud, or obviously after a dynamic consent acceptance by the patient. So we began to develop a first prototype based on the models available in the repository from the openEHR community that at that moment was already translated in Italian. And we shared this first prototype with the clinician from the Brooks Hospital in Cagliari, and in particular with the nephrology department. And so we started to receive a lot of feedbacks from this first prototype, application prototype. In the meantime, also the regional healthcare agency was working on an assessment infection risk questionnaire, which was, of course, different from the one used to develop the first template. Ian, correct me if I'm wrong, but it was based on the WHO assessment questionnaire. But of course, it has a lot of similarities. So we put together the feedback from the clinician and the Sardinian questionnaire, and we started to develop a new model. And in this slide on the right, you can see the result of this new model. So based on this new model, we started to customize our previously developed prototype, and we succeeded to release a fully functioning one in a very few weeks. The application itself is very easy. It allows to identify the patient and then submit the quest also and submit the questionnaire in an openEHR format, submit to a CDR, to clinical data repository, for later use. The objective was also to let the application be able to retrieve also the results from the swab analysis and present all the history related to the exams and the questionnaires of each patient. And after this development, we made our models available to the community, and we received a lot of feedbacks to increase the quality of our work and make them more openEHR, let me say openEHR compliant. Okay, in this picture, you can see that the complete solution that we delivered in the Bronx Hospital, where our solution was composed basically from 3 different applications. The COVID app I mentioned before, the product system, which is a system for collecting tools and trace all the collection associated with it. And finally, the TPM, which is a platform based on the concept of personal people going in the cloud. In the beginning of our effort for this initiative, we planned to deliver this entire picture so that all the information associated with the swab collection and risk assessment could be made available to the patient himself through the TPM. But in the end, we succeed to deploy the COVID application into the nephrology world inside the hospital products too. We succeed to integrate it with the hospital information system. And now we are still working on making the data available also for the other system inside the hospital. So I just want to close this very brief presentation with some lessons learned from this initiative and some takeaways. The first point was that joining the community effort in responding to these COVID energies for us was a very winning strategy, because it allowed us to respond very quickly to a new born situation, which was very dramatic in Italy at the time. And it also gives us a lot of background, and also the use of the clinical models that were already available in the central repository of the openEHR community, and allowed us to communicate very easily with the clinician and to reason about the assessment application very easily, And so I would say that taking part in this initiative was very successful for us to deliver this application in very few weeks. And from another lesson learned was that by developing our application using the already available platform, it allows us to concentrate ourselves to the application development without caring about all the stuff related to the data management. And so this also saved a lot of time. And once again, we succeed to deploy this application very. Okay, so I just finished my presentation, my very brief history of our effort in COVID-19. So I will pass the word to Heather, and thank you all.
Thank you, Paolo. So I'm Heather Leslie. I'm a clinician. I'm a GP, primary care clinician in Melbourne in Australia, and a health informatician for the last 20 years. Australia's done very well with COVID up until the last few days. And in fact, today, my city of 4.5 million people have been put into lockdown for the next 6 weeks. So we're just facing our second wave here, and it's becoming more and more a critical thing, but a long way behind some of the other countries. So it's of interest, certainly from my point of view. I wanted to introduce you to a tool that we use within the openEHR community. So Silje, who I introduced briefly before, and I are the co-leads for the clinical modelling program at openEHR International. And we use this online tool, and you can see the URL down in the bottom right-hand corner. And this is a tool where we have a library of where people have been talking about archetypes and templates, and I'll explain them a little bit more. So it's a public library of freely available information models. It's a collaboration portal where we get, you can see we've got 2,485 users from 103 countries as of today, who've registered and who are able to participate in a review process. And it allows us to do the governance that we need around the models so that we can publish them from a content point of view and a translation point of view. And we can also manage versioning, etc., so that we can manage things with our vendors from implementation changes, etc. So our approach to clinical content is we've developed things called archetypes, which are information models based on a single clinical concept. So they can be anything from a couple of data elements through to 10, 20, 30, or sometimes even 40, although unusual. So these represent a single clinical concept, like a medication order or a diagnosis or a goal, a questionnaire. The templates where we aggregate these archetypes, so we can have anything from 1 or 2 archetypes right through to, in some complex situations, we can have 40, 50 or 60 archetypes to represent something like a complex consultation note. And we aggregate the archetypes, so we can have 40, 50 or 60 concepts in that case, and we can strain them from a maximal data set in design down to something that's very practical for the particular use case. So if an archetype's got 10 data elements, if we only need 2 for that particular clinician in that particular scenario, that's all we actually reveal to the clinician as they enter the data. And of course, we need to use terminology as well. So the terminology and the information models work critically together, and the clinicians lead this. This is what's quite different, I think. So we're proactively building information models to gradually cover more and more of all of the healthcare domain. So if we take this premise of the archetypes, the templates, and then the terminology together, we use those to build data sets. And those data sets can represent documents, forms, messages, schemas, whatever you might want to do, but we do them all so that they're consistent, so that the archetypes and the templates are providing the consistency at that very left-hand side, and whatever comes out the other side at the right-hand side, we're using the same concept. So the problem diagnosis archetype would be used between documents, forms, messages, etc. We also use them to build our decision support processes, and we have an open source specification for the guideline definition language. We also use them to build semantic queries. So all of the querying, all of the decision support is also based on those same information models, along with terminology like synonym, link, etc. And this is where we're quite different to the other kinds of standards out there who are focusing on this right-hand side of building documents and forms and messages, which means they're often not well coordinated. We instead focus on this side so that when we get to build the documents and forms, they all are coherent with the archetypes at the beginning. So what I'd like to do is try and express that in a slightly different way. So I'd like you to suspend belief just for a little bit. If we think of this Lego city as being the clinical content of an electronic health record. So you can imagine that underneath what you can see in all of the buildings and the vehicles and so on, there's sewerage and there's electricity and there's the fire brigade and all of those kinds of things. And they're the equivalent of our security, all of the architecture that sits beneath it, all of those kinds of things that we need to run an electronic health record. But the blocks themselves are building things that are related to our clinical content. So that's the way I'd just like you to be imagining this. So if we take that city and we start to deconstruct it, you can see that we've got cranes, we've got helicopters, we've got buildings. So you can see things that you recognize. If we could deconstruct those further, we get piles of blocks. So Lego, I think most people would be familiar with them as building blocks that you can plug and play together, different sizes, different colors, and you can create things with them. And you can get some quite specialized ones as well. But underlying this, the rules of Lego are very, very well defined. If that little round knob on the top is not 4.8 millimeters across, like it says in that little diagram, then it won't fit into the next block. It'll be either too tight or too loose and they'll fall apart, etc. So this is, in our world of openEHR, this is what we think of as the reference model. It's the rules of how all of this works together. So in technical terms, you think of those as being the data types and all of the kinds of underlying rules that you need to make an electronic health record work, how you record consistently who the patient is, who the author of the record is, what date it was, those kinds of things when things were recorded. These building blocks in the openEHR we're thinking of as archetypes. So there is specification for each clinical concept, and they are what creates our health data patterns. We standardize them, we get clinicians to agree that they're fit for use, and then we govern them really tightly within our clinical knowledge manager that we just looked at briefly before. And then this next level up is the equivalent of our templates, which represent the data sets. So they're our clinical documents, our messages, our forms. They're when we aggregate those building blocks from the level below so that we can manage clinical diversity that can be specific for any clinical domain, a particular profession or a geographical location, whatever that clinician needs in that particular situation. So what Ian started with, it's a couple of is this app on the left, and this website in the middle. So these are some of the UK resources. He also used, I think, some of the WHO resources and maybe CDC as well. So we were basically pulling what we could from apps, websites. On the right-hand side is in fact the official Chinese guidelines for diagnosis and treatment of COVID. So that is effectively just a Word document. And these were the kinds of things that we started with to give us our requirements. And what we did was, if we take those documents, we had people analyze them, and they actually worked out which of these concepts, which of these little archetype blocks we could start to reuse. And so they actually deconstructed those documents and worked out what the archetypes might be as represented by those building blocks. And so what happened with it, I'm going to speak on behalf of Ian here, he looked at those ones and he actually decided they actually needed a few more. So we took the existing ones and built some extra archetypes. Now, when I looked at the data set, I would estimate that his reuse of the existing archetypes in CKM was at least 80%. And he built, within a few days, some very quick archetypes to try and cover the requirements that were in the WHO document, CDC, and from the NHS. And so he's built the equivalent of this fairly simple little helicopter to represent the data sets using those archetypes. And we put them into CKM, and we put them into a thing called an incubator. So the incubator is a space where we put the fairly new, immature templates or archetypes that we're sort of working on. It's a place where people can collaborate. It's a place that people can go and find other resources and that perhaps take them for themselves as well, start to use them, start to share them. But it's not a governed space, so there's not strict rules around it. So it really does, it's more like a sandpit idea. And so that's where, you know, effectively what Paolo's done is come in and taken the work that Ian started, took that as a starting point. He's tweaked it. He's turned it into a nephrology focus, and some other aspects have been changed to suit his implementation in Italy and also translated into Italian. So effectively he's got a purple version of that red one originally, if you like. So the similarity and the commonality between what Paolo has just implemented and what Ian and the Norwegians have implemented are incredibly similar. But that was all done in the very early days, and it was also done in a very fast pace. And what Silje and I were able to do with a little bit of time, still only a week or two, but we were able to look at those templates and we started to analyze them, and we were able to actually tease out a few more in a slightly different format. And we built some extra archetypes, and we created a representation of Ian's original template with some of these new building blocks. So again, it's a helicopter, but it's a little bit more fancy. It's a little bit more robust, if you like, just from the image. And we've uploaded them to another part of the clinical knowledge manager. We uploaded it into a project. And the project is where we've actually got a governed space. And so the archetypes that we built were basically to take Ian's very quick ones and actually turn them into something that we could see not only would work for this particular COVID project, but also for a multitude of other projects. So it really didn't have any particular focus. So things like we created a specific archetype around a travel history so that we could record where people had been and where they might get risk from their travel experience. There were some other ones around questionnaires, so just symptom questionnaires that we did in a structured way so that we could reuse them. And we're already reusing those archetypes in other projects that are non-COVID related. So this is the way we start to build up the library in the clinical knowledge manager. But you can also see we've got the ability to actually move very fast and still keep it in that in the CKM space so we can share it, that we can translate it, but we can also have ways to move that forward so we can govern it and they can actually be reused in better ways in the future. I've also done some mapping between Ian's original template and the templates that we've built for the project. And in fact, we can map them one-to-one in about 99% of cases. So anyone that's using those original templates in those very, very early implementations has a forward path to be able to move them forward towards the the newer, more mature archetypes as well. So again, it's just part of how the community is working together and collaborating so that we can make sure that there's all of this data. In fact, whatever has been done in Ian's Norwegian work, the UK work, and the Italian work can actually move forward into this project work. And Xudong is going to tell us about how he's taken the work that's actually in the project, and that's what they've been implementing. But it still means that all of the data that's been recorded using the early work and this later work is also going to be able to be aggregated and mapped if we need to. So there's commonality in most of the information models. The ones that aren't, we know that we can map them, and we also know that we can work across the languages as well. I'm going to hand over now to Jidong. He's going to tell us a little bit more about that project.
Okay. Hello, everyone. So my name is Jidong Liu, and I'm coming from the Zhejiang University of China. So I list here several other names, and they are also my team members and work together with me for the implementation of the openEHR in China. And I'm working in the academia area, so we are working on openEHR from the 2010, and we have developed the openEHR based CDR systems. We named it Clever, and also we have some case studies in the hospital. So maybe everyone knows, so the COVID-19 is started from China, so I will tell the stories we experienced on how to tackle with the outbreak of COVID-19 in the hospitals. Okay, so so that's it. So this the story happens in one hospital in Wuhan. So Wuhan is the first city have been experienced for the outbreak of COVID-19, and we have the partner hospitals in Wuhan. The name is the Central Theater General Hospital of PLA. It's Army's hospital, and it it's big hospitals in Wuhan. It has 8,000 outpatients daily, and have 3,500 beds in the hospital. And so far, it admitted 700 patients, and all of them are severe cases. And we have cooperated with this hospital since 2018, and our Clever system, so openEHR based CDR, have been implemented since then. And the CDR have collected data from different legacy systems, including hospital information system, the lab information system, EMR, and the radiology information system, etc. So those data have been all accumulated in one CDR, and the CDR provided the neutral technical platform, and the data have been defined by the archetypes and the templates. So totally, I listed the number of the archetypes and the templates we have been used, and those archetypes and templates have been maintained, updated by the hospital staffs after it has been implemented in the hospital. So the different apps, including clinical decision support, research, and patient services, and data exchanges have been developed and worked on this CDR. And so in the case of outbreak of COVID-19, I will express two stories to how we met the challenge of these events. the first challenge is just in the very beginning of the outbreak of COVID-19, because it's a very sudden events. So the hospital have met a very big challenge, because the sudden influx of patients caused the very much problems of medical resources. So it was very necessary for the hospitals to the data reporting requirements, because in time reporting is very important for the managers of hospital to coordinate the medical resources to support this event. And I will tell the story about how our openEHR based solutions to provide the good tools for them to facilitate the data reporting for the management requirements. So the second challenge will be not in the very beginning, but after the very sudden events have been passed. So especially in current days, not many patients in the China now, but in Chinese government, they still take it very seriously for prevent the risk of a secondary outbreak. So we have developed this system based on the openEHR archetypes and the GDL for the diagnosis of screening. So I will tell the story about this too. Okay, so let me explain the requirements of the first cases. So in this slide, I listed several data reporting requirements from the hospital level and the government level. So the hospital have needed to provide the reports very quickly. And also the report requirements have been changed very quickly, because every day, even in those months, even every day the requirements will be changed. And the situation for the hospitals is because for the traditional method, if some management requirements have proposed, usually the statistic department need to define the indicators, and also to need to capture the data from the system, and to provide to develop the software. It need a lot of time, and especially in that very special time, the Wuhan city, in February and March they are closed. So the developers, the vendors cannot go into the Wuhan, and so the remote support is not so enough. So in this cases, our openEHR solution is very good, because the users, I mean the IT staffs and the clinicians, they can define their templates and provide and configure the reporting tools. And so I have posted this work in the MedInfo 2019. So we have developed the we have combining the clinical quality language. It's a work from HL7, and we linked the CQL and the archetypes together, and we developed the tool for the CQL editor to define the clinical quality indicators. I mean, to define the indicators and based on the openEHR archetypes, and also we developed the report design tools, then provide the tools for the clinicians and the IT staffs to configure the reporting user interfaces, the reporting apps for the management requirements. So the flow just like this. So if there are some data reporting requirements, so the hospital management, they will provide the requirements. The statistic department, they will propose some indicators for the information department. So they will using our tools to define the indicators, and the statistics staffs will design the report view apps and provide the application for the management requirements. So those configuration can be done very quickly in the hospitals. They can do it without our support, and it helps very much for them to meet the requirements in this very sudden events. So those are applications configured by our clever CDR, and they can support the requirements for the data reporting. So this is one case. It works very well to show the quick response of the openEHR solution for the requirements, data requirements needed. So the second case is I will explain about the clinical decision support system. So you know, especially this month, several cities like Jidong, Beijing have also happened new cases for COVID-19. So the government is worried very much about the second breakouts. So our tools are targeted for that, and we are working on two scenarios. So one scenario is that we can do the diagnosis of decision support at the clinics, and the second scenario will be the screening of suspected cases in management department in hospital in case in clinics the patient have been misdiagnosis or this. So this decision support tool are based on the computer interpretable guidelines, and it's based on the guidelines, the 7th edition guidelines developed by China, and it's also mentioned in Heather's slides. So we use this flow to develop our decision support tools. So we will analyze the guidelines text and extract the main concepts and also the clinical rules from the guidelines, and the concepts are modeled by the openEHR templates, and also the clinical rules are defined can be defined by the GDLs, and those two artifacts can be filled in the openEHR based CDR architecture, and to support the CDSS applications. And so the main concepts modeling. So we have also worked together with Dr. Heather Leslie, and we captured all the domain all the concepts from the guideline texts, and we search in the existing the archetypes in the CKM, and finally all the data required for the decision support can be found the corresponding archetypes in the CKM. So actually we do not create new archetypes for this work, and this work have been already published in one paper, and also you can find the templates in the CKM now. So after this, we use the GDL to authoring the rules, and it's including the diagnostic criteria, the clinical classification, clinical warning, and also differential diagnosis. It's almost covers all the aspects in the guidelines. And so this is the two applications we have been used. This is the rules we have been published in the GitHub, and also we have the announcements in the disclosure. So these are two applications we developed for the two scenarios. So it's I'm sorry. So the left one is for the decision support for clinics to help the doctors to checking whether the patients have the COVID-19 or not. And the second one is for the management. It's the everyday the management department will checking all the patients in the outpatient department to see whether there are some patients possibly have the COVID-19 diagnosis. Okay, so it's almost the timing. So our this is a conclusion page. So we think the openEHR methodology can it's very promising to rapidly meet the sudden requirements, especially in this event's outbreak of COVID-19, and also the cases for the we learned the lessons we learned in COVID-19 also can be used for other diseases, and we also met the problem because especially this our CDI have been used in the hospital. Now the hospital staffs are configured their own archetypes and the templates, but usually they forgot to, or they know little about existing archetypes. So most of those archetypes are not so good. It will be still more training is necessary for the hospital staff to learn that. Okay, so okay, that's all. So I'll hand over back to Heather.
Thank you, Jidong. Sha, I think we're very close to time, so we've taken a little bit longer than we anticipated, but we're very happy to take any questions from anybody who would like to ask them. I'll leave that up to you.
Thank you, Dr. Heather. I think questions were also answered in the chat box, so I will be including them in the recording. So before we end the session, I would like to call on Dr. Alvin Marcelo, Executive Director of the Asia eHealth Information Network, and Dr. Shinji Kobayashi for some message and announcement. Thank you.
Thank you, Cha. Heather and team, Ian, thank you very much for hosting this call. I think we need another one. Let's get a poll of what the audience tonight would like to know more of, and then we'll feed that back to you, Heather, and then we can have another planning. But definitely, I think I'm very much impressed with the speed by which the archetypes for COVID were created by the team, and congratulations for that. So hope to see you again in another call, another webinar. And I pass the mic now to Shinji.
If you are interested in this openEHR talk, we will make a seminar in July 24, 9 to 11:30 in Manila time. Good morning to Asian people and good midnight to European people. Please stay tuned to this AeHIN hour. Okay, thank you.
Right. Thank you so much, everyone. Good night.
Thank you, everybody. Thank you for having us.
Good night. Bye-bye.
Good night.